Mhm.
Welcome to TFI's next episode of Talk to the Doc. Today we're talking about IUI, intrauterine insemination. We get a lot of questions about what is IUI, may IUI potentially be helpful for us. So we're going to take about 10-15 minutes today to review what an IUI is, how it potentially could help couples get to their goal of getting pregnant, but also importantly, kind of know when to stop with the IUI if it's just not working. So we're going to talk a lot about numbers today. We're going to talk about percentages. We're going to talk about who's a good candidate for IUI, which couples aren't good candidates. As always, we encourage any questions that you may have if you want to send those in to us. With my trusty colleague, Jenny, today, so she's going to be fielding questions and she'll keep us on task. So an IUI, an intrauterine insemination, is where we can process either a male partner's semen, or we can use donor sperm that's been previously collected in our laboratory and prepare it for injection inside the uterine cavity. There are two different forms of preparation for an IUI. The most common is called a sperm density gradient IUI, where we collect the semen sample and our lab technicians wash it at least 2 times in a special buffered saline solution that washes out dead cells, cells that may not be healthy. And then they spin that sample down in a centrifuge to collect a concentrated sperm pellet. They then resuspend that pellet in a very small volume of that same buffered saline, and then they hand it off to us in the clinic side, where we use a very small catheter, and with a speculum exam, we guide that catheter up into the uterine cavity, and we gently inject that sample into the top of the uterus. The benefits of doing the IUI wash is that we get a much concentrated sample of sperm. So that's really important for guys where they may not have as high of a concentration on their semen sample as we would like. But the other interesting thing is it helps those sperm swim faster. So sperm actually get activated to swim better when they're in that wash in that special buffered saline. The second form of sperm preparation isn't as common for IUI, and it's called a density swim up method, where we think the healthiest sperm swim up towards the top layer in the test tube, and then we can use those sperm for the actual insemination process. Again, that technique isn't as common for IUI. We use it in the IVF lab where we're dealing with fewer sperm that we need. So it's almost always that centrifugation where we concentrate the sperm sample into that little pellet. The procedure itself is really simple. It takes about 10 minutes. We sometimes have people come in with a full bladder. So the partner comes in to collect the sample, usually about an hour and a half to 2 hours before the actual IUI. We have a private collection room where we do the collection, and then the processing is done in the laboratory. And then about 90 minutes to 2 hours later, we actually do the procedure in our exam room. For our female patients, it's really no different than having a pap smear. It's a short speculum examination. Sometimes we have women come in with a full bladder. A full bladder actually helps push the uterus more straight, so the catheter goes inside the uterus a little bit better. If we ever have problems getting the catheter inside, we'll do ultrasound guidance to make sure that we're putting that catheter right where it needs to go. After the procedure is completed, we have patients wait for about 3 to 5 minutes after the insemination, and then they're good to go about their usual daily business. Really, the goal of the IUI, so not only to get more concentrated sperm and to help them swim faster, but it's to get those sperm past the cervix. And the cervix of the uterus can block sperm from getting into the uterus during normal intercourse. And so by bypassing the cervix, we get a lot more sperm inside the uterus, and we think that's why it helps couples achieve conception better and faster. There are very few risks with the IUI procedure. Some women may have a little bit of bleeding or cramping afterwards. But most people do just fine. 2 weeks after the procedure, we check a urine pregnancy test and we find out if it works. There are sometimes questions about contraindications to an IUI. When might an IUI not want to be performed? Really, the first one that comes to mind is if a person has any kind of abnormal vaginal bleeding that doesn't have a diagnosis. We want to make sure that we know why people are having abnormal bleeding before we do an IUI, so we can really make sure that everything's normal inside the uterus. Abnormal bleeding can be caused from a variety of things: a thickened lining, ovarian cysts, but also infections. We want to make sure that another contraindication to doing an IUI is an active pelvic infection. But otherwise, there really aren't very many contraindications to doing an insemination. Insemination can be really helpful for lots of different reasons. There are some couples who aren't able to have intercourse at home, either due to vaginal discomfort or pain. Sometimes men may have problems getting an erection or maintaining an erection for intercourse, whereas we can collect those samples with masturbation in our collection room. So those are often ways that we can bypass tricky issues that may keep intercourse from happening at the right time. And stress plays a huge role into it too. We know that if people are checking ovulation kits and they know that this is the magic time during their cycle, sometimes that makes it difficult for some partners to get things happening at the right time. So by doing it in a more controlled setting in the laboratory and in the office, that can really be helpful for a lot of people. So those are kind of the basic points of doing an insemination. I think if you look overall at numbers, so one of the big questions is, I have a low sperm count. Is insemination really the right step for us, or do we really need to go straight on to IUI? When we do a standard semen analysis, the normal concentration of sperm should be above 15 million cells per milliliter. But we know that as sperm counts drop, fertility rates start to drop at home. So really, we recommend IUI in a couple different scenarios, but if it's strictly for male factor or strictly for sperm counts, if the concentration is below 13 million cells per milliliter, then we think that IUI is then indicated. If sperm concentrations on the IUI wash are then between 5 and 10 million total swimmers or motile sperm, then we think that IUI is still appropriate. But after that sperm wash, if the motile sperm count is less than 5 million, so now we've taken that whole sample, spun it down. If we have 5 million or fewer sperm, we do start to see pregnancy rates drop off. And if it's less than 4 million, then really couples only have about a 1% chance of having conception with an IUI. So that's 1%. It's a pretty small number. And so one of the issues that we often hear, one of the myths of IUI is we often have couples think that their chance of pregnancy is going to be between 30, 40, 50% each time they try, but it's much smaller than that. But in terms of sperm counts, if we're around at least 5 million cells or higher, IUI does have the potential to help. But if sperm counts are less than 5 million, that's really when moving straight on to IVF becomes the best option for pregnancy. And that's because with IVF, we can use just a very small number of sperm with still really great success rates. So the next question is, who are really candidates to do IUI? Is it specifically for one subset of patients who may have polycystic ovary syndrome, for example, or is it for all comers, all couples who want to get pregnant? And it really is for all couples who either have been trying for a long time to get pregnant and they want to boost their chances, or if they have specific conditions, we recommend IUI. So low sperm counts is certainly one, but one that a lot of people don't think about are for couples who have unexplained infertility. So unexplained infertility affects about 25% of the couples that we see, and that's where all the testing that we've done, including the sperm test, the tubal dye study, and ovulation kit testing, and hormone testing, everything's normal, and we can't come up with a reason of why couples can't get pregnant. And studies have shown that in couples who have unexplained infertility, if they just do basic ovulation therapy, say with Clomid or Femera, their chances of pregnancy don't really go up by a lot. But several studies have shown that if you add Clomid or the Femera with IUI in couples with unexplained infertility, that's when we start to see pregnancy rates go up. So there's not a lot of benefit in couples who have unexplained infertility of just doing Clomid. You really do need to add the IUI. And so the thought is now we're taking both factors. We're taking eggs and we're trying to boost egg development in the ovary with the pills like Clomid. And then we're also now using the IUI to try to get the sperm up inside the tubes as best we can. The sperm actually end up in the tubes within 5 minutes after the insemination procedure. So they get really up in there really quickly. So that's one group that we think that IUI is really important for, couples who have unexplained infertility. For women, for example, who have polycystic ovary syndrome, where they may not be ovulating well, we know that their main issue is typically ovulation. But we know that there are some limitations with just doing ovulation therapy. In one study, for example, looking at over 410 different patients, not necessarily just in PCOS, but in couples overall using Clomid, they found that after 2 cycles of using Clomid at home and not doing inseminations, the pregnancy rates started to fall. So it's then, even after just 2 cycles, that if we add in IUI, we may potentially help with success. So if women have polycystic ovary syndrome and they're ovulating fairly well on just Clomid at home, we know that the pregnancy chances are going to start to go down pretty quickly. But by adding an IUI, with say the third, fourth, or fifth cycle, that can help those patients with PCOS get pregnant. Endometriosis, we know that can certainly affect fertility as well, and that may be more for from a tubal damage perspective. But we know that getting sperm up inside the tubes can be helpful for those couples as well. So there are really very few instances where IUI can't be of benefit, and certainly we don't know of any instances, with the exception of abnormal bleeding or pelvic infection, where IUI can cause harm. So it really does give couples that extra little push and that extra benefit to try to get them to where they want to be. So now we've talked about sperm counts, who are candidates for IUI, who aren't. Now it really kind of comes down to crunching numbers. Who gets pregnant after IUI and who doesn't? And so there's a lot of different research, a lot of different studies looking at really the best way to offer patients therapy, but also a realistic understanding of how well these therapies can work. And as we've been talking about throughout the last year, the number one factor that's going to impact a couple's chance of having success with IUI is the female partner's age. We know that eggs age over time, and we know that is the most important factor for getting pregnant. So if for women younger than 35, we know that IUI is going to work better than women who are over 35, primarily from just an egg standpoint. So when we talk about success rates, it's very important to talk to your doctor about, number one, what's my diagnosis? Number two, how many cycles of ovulation therapy do you plan on keeping me on before either referring me for an IUI or considering IUI? And then number three, what really are my chances of pregnancy, not just each time I try, but over time? What's my total chance of being able to get pregnant? So when we counsel our patients, we not only talk about per cycle pregnancy rates, we also talk about the chance of getting pregnant over 3 or 4 cycles total, because most pregnancies are going to happen within that time frame. If couples aren't pregnant within 4 cycles of ovulation therapy, and especially 4 cycles of IUI, then we know the pregnancy rates are really going to start to go down. So if you add in age, and if you look at the overall chance of age, I'm going to break this down into the different age groups that we look at. For those of you who are 35 or younger, your average chance of pregnancy, and now we're talking about, say we just have unexplained infertility, and we're looking at adding in fertility therapy like Clomid with IUI. The average chance of pregnancy per month that you do Clomid and IUI, based on one study of around 4,200 patients, over 1,800 different cycles, they found that the per cycle pregnancy rate, so each time you try, for women younger than 35, is 11.5%. So I often counsel patients, you have about an 8 to 12% each month that you try to do an IUI. But in that same study, looking at those 4,200 women or those 4,200 couples, they found that only about 25% of women overall were going to get pregnant with Clomid and IUI. So not everybody's going to get pregnant when they start doing IUI. About a quarter of patients overall will have success over 4 months. Now, if we look at women who are 35 to 37, and you look at their average chance of pregnancy per month, each time you try IUI, your chance is about 9% per cycle, and about 18% of couples overall will get pregnant after 4 months of therapy. For women 38 to 40, now the average per cycle pregnancy rate is about 7%, so about 7% each time they try. And then overall, the chance of pregnancy after 4 cycles is about 15%. And then for women from 40 to 42, we know that the per cycle pregnancy rate, again, each month that you try, is about 4.5%. And over time, about 12% of those couples overall will get pregnant after 4 cycles. And then for those women who've passed their 42nd birthday, unfortunately, we know that the per cycle pregnancy rate is only 1%. And so typically, I don't recommend attempting IUI if a woman has passed her 42nd birthday, if she's 43rd or older, because we know that the chances are going to be quite low. Now, I do make an exception because there are some couples who say, well, maybe my egg numbers are really low and I've been counseled that I'm not a very good candidate for IVF. Can we try something? And so I certainly think that that trying something and doing something like IUI, or maybe just adding in some injection therapy, can potentially offer some chance. I often say that there's no way I can say it's a 0% chance, but we do know that as women get over 42, that those options do become much more limited. The last thing I was hoping to talk about today then too is, what about the different therapies? Is there much of a difference between Clomid or Femera? I call it letrozole, FSH injections. What if I do ovulation monitoring at home as opposed to doing ultrasounds and triggering my ovulation? These may be terms that a lot of you have heard. They may be terms that you haven't. But we do know that in general, Clomid and letrozole work pretty similarly. There are some studies to suggest that pregnancies with letrozole might be a little bit lower than with Clomid, but there are some studies to suggest that they may be a little bit higher. So there's not one black and white answer to that. I think the important thing is, as long as women are responding well, they're having good ovulation kits at home, or we're seeing good follicle development on ultrasounds in the office, and those are all encouraging signs. We do start to get into concerns, though, once we start using injection drugs. Injections are a purified form of the FSH hormones, and now we're directly stimulating the ovaries to make egg follicles. And the big concern there is multiple pregnancy, not just twins, but triplets, quadruplets, quintuplets, so the scary stuff that we hear about in the news a lot. The risk of having a multiple pregnancy when you use injections with IUI is around 36%. So 1 out of 3 pregnancies will be a twin or higher. And we know that 60% of all cases of triplets, quadruplets, quintuplets in this country happen from those injection cycles. The risk of twins is much less on Clomid and letrozole. On average, it's about an 8 to 10% risk of twins per cycle. But it's really when we start getting worried about twins and multiples is when we start using those injection therapies. So if anything, I go back to the starting block of saying, make sure you know what your diagnosis is. Make sure you have a good discussion with your doctor about how well these cycles may work, and have a firm understanding from your physician or from your treatment team about how IUI may potentially be helpful for you. I think one of the big things that we try to do in our office is we often see couples who've been on a long course of just ovulation therapy, either 3 to 6 months of Clomid, and then finally the decision is made to try IUI. We like to intervene sooner than that. Again, if couples aren't pregnant after 2 cycles of Clomid, that's really when IUI should start to be discussed or raised as an issue. Often I'll have couples ask me, I've been on 3 cycles of this or 3 cycles of this other thing. Is there some magic between 3 cycles before moving on to IUI? And the straightforward answer is, it's based on those studies that show that if pregnancy hasn't happened within 2 to 3 cycles of just ovulation therapy, that then we should consider IUI. But also, if it hasn't happened within 3 cycles of IUI, then we really do think that moving on to IVF is going to be in the couple's best interest. There was one really important study looking at the role of ovulation therapy, IUI, and moving on to IVF, and it's called the Fast Track and Standard Treatment Trial. And they found that couples who did 3 cycles of Clomid with IUI, then went on to 3 cycles of the FSH injections with IUI, and if they still weren't pregnant, they went into IVF. And they compared that with a faster arm. Couples who did 3 cycles of Clomid with IUI, and if they weren't pregnant, then they went straight to IVF. So that's the faster track. And they found that couples who went on to IVF, skipping the injections and the IUI, got pregnant on average 11 months faster, and they actually saved about $9,800 per pregnancy compared to the couples who went through all of those different cycles of IUI. And so I think that highlights the importance of 2 things. Number one, Clomid IUI, Femera IUI can be great options for therapy for some couples, but only about 25% of couples overall will get pregnant with IUI therapy. And the second point that I think is really important to remember is, if it's not working, you need to talk to your doctor about what other options are there. And that's when we think that going into IVF and more aggressive therapies helps you get pregnant faster with much higher success rates and even lower cost. So those are the big things that we wanted to talk about today. I'm going to pause there, give you guys any chance to ask questions. I'm going to just look over here at Jenny and see if she has any for me.
I've got one that is coming through right now. Can you see it on the screen? No, you can't. Hold on.
Okay, cool. So the question is, can you continue to have intercourse if you're doing an IUI? Absolutely. I encourage people to have intercourse the same day or that evening that the IUI is performed. I tell people that any extra little bit can help. There's nothing that can preclude you from doing IUI. So we'll usually have patients come in the morning for their IUI procedure, and then I encourage patients to have intercourse again that evening. The eggs can live for anywhere from really 2 to 4 days, sometimes 3 to 5 days. So I got that backwards. Sperm can live for that long. Sometimes being on Facebook Live makes me a little nervous. Sperm can live for 3 to 5 days. The egg can only live for about 12 to 24 hours. So that's why we really try to time the insemination procedure with the ovulation kit, or we do it with HCG trigger, so we really know when we're timing the insemination. But because that egg can still hang out and survive for 12 to 24 hours after ovulation, we try to time the IUI with the egg release. But then it's important maybe to have intercourse again 12 hours, even 24 hours later. So that certainly can help. It brings to mind another thought. A lot of couples ask me, should we do 2 IUIs? Should we do back-to-back IUIs? In one study, looking at over 15 different individual studies looking at the timing, we don't seem to think that there's much benefit of doing a second IUI. There are some select studies, though, that suggest that pregnancy rates may go up a little bit, again, maybe 1 to 2 percentage points when you do back-to-back IUIs, but that really adds to the cost without much of a benefit. So we really do typically recommend 1 IUI. And again, those IUIs can be timed just to ovulation kit testing. So that's where you check urine in the morning, and then you let your doctor's office know in the morning. They get you in the next day for the IUI. Or we often do ultrasound monitoring, looking at follicles, triggering follicles. We think that we might help with timing a little bit. But to be honest with you, most centers don't have much of a difference in terms of overall success rates, whether they use ovulation kit testing or if they do the ultrasounds. I think ultrasounds can be important just to make sure that people really are responding to medications as they should, to make sure that we're not missing an ovulation or late for an ovulation. Are there any contraindications to IUI? Really, the only ones are abnormal uterine bleeding, potentially pelvic infections that are undiagnosed. So I always want to make sure that if there is any abnormal bleeding, that we have a diagnosis first so we figure out why that's happening. But otherwise, no, there are really no contraindications. Things that can make an IUI more challenging, there are some women who've had significant cervical surgery. So if they've had a cold knife cone biopsy, sometimes that can make finding the opening of the cervix quite challenging. But from a technical standpoint, from the actual procedure itself, it's a relatively straightforward procedure. So really no contraindications that come to mind. Obviously, it can be based just on an individual circumstance. But my big things are you want to avoid active pelvic infections. So if there are any signs or symptoms of that, like abnormal discharge, abdominal pain, fevers, you want to rule that out. And then any undiagnosed abnormal bleeding. All right, you guys. Thanks so much for joining us. Give us feedback at any time if you'd like to. We're trying to switch up the times a little bit. Some people can tune in at the 6 o'clock Facebook Live. We tried this as our first one over the noon hour. So if you have any recommendations about times that we can do, if there are any topics that you want us to talk about in the upcoming months, please feel free to let us know. We really appreciate all your support out there. Keep the questions coming, and we hope to see you soon. This is Dr. Christopher Montville. Have a great afternoon, and we'll hopefully see some of you soon. Bye-bye.